Hey everybody, thanks for tuning in to episode 3.5. This is the abridged version of thyroidectomy. Really what we're doing is talking about the important anatomy for a thyroidectomy so we can stay safe. Again, I'm Josh Dremiel, I'll be your host. This is the layers of the cervical fascia, just to make sure we're all on the same page. This black line is your skin and subcutaneous fat. We have to enter that. This next line is the platysma, or the superficial cervical fascia. We'll obviously have to enter that. Next, we have the superficial layer of the deep cervical fascia. We'll enter that right in between the strap muscles on either side. And then we'll make our way to the visceral fascia, which contains the thyroid gland. As we're looking at the steps of the procedure, obviously the first thing is a horizontal incision, and we will raise some subplatysmal flaps inferiorly and superiorly so that we can retract in those directions. And once we get past the platysma, and obviously the skin and subcutaneous fat, we get to the superficial layer of the deep cervical fascia, which contains the strap muscles. Right in between these two bellies of the strap muscles is going to be the median raphe. So here's strap muscles, here's median raphe right here. Okay, now that brings us to a quick discussion about the different muscles of the strap muscle group. Really the more appropriate name are the infrahyoid muscles. And one common question is, which muscle do you encounter first? And that is the longest muscle, and it has to be that way if you just think about it, which is going to be your sternohyoid muscle. Next, we have the sternothyroid and the thyrohyoid muscles. So those are underneath the one long sternohyoid muscle. And just lateral to itself, to everything else, is going to be the omohyoid, which has a superior and inferior belly and is going to run from your hyoid bone all the way back to your scapula. Now that we've cut down the middle of the median raphe and we've spread those muscles laterally, so we have platysma superiorly and inferiorly, and we have strap muscles laterally, we've now made our way to the thyroid gland, and we can begin the real bulk of the surgery. I know this is a really busy slide, and I apologize for that, but we'll take it stepwise, and I think we can get some good ideas of what's going on here. So in green is our thyroid gland. The important part of this is that it has two arteries, the superior thyroid artery and the inferior thyroid artery. The superior, it branches off, and it's actually the first branch of the external carotid artery, while the inferior thyroid artery comes from the thyrocervical trunk. Don't forget that thyrocervical trunk. Attendings love to ask that question. Next thing here, we have three veins. They're not as important, but just know that we encounter the middle thyroid vein on its own. It doesn't have an associated artery. Also, I lack to mention, sometimes, I don't know a percentage, but not very often, there's an IMA artery, which comes off of either the innominate or the aorta. There's four parathyroid glands, one in each pole, although they can actually be all over the place. But there's one relationship that is never different, and that is that the inferior parathyroid glands are always ventral or in front of the recurrent laryngeal nerve, while the superior glands are always dorsal to the recurrent laryngeal nerve. Furthermore, people love to ask which pharyngeal pouch do these derive from, and the inferior are the third and the superior are the fourth. So just another little factoid to know there. And then finally, the last and probably the most important part of the surgery is that the recurrent laryngeal nerve runs right in the tracheoesophageal groove before it enters near the cricoid. And it comes off of cranial nerve 10, and cranial nerve 10 comes all the way down and then gives off this branch called the recurrent laryngeal that comes up to give function to the vocal cords and the intrinsic musculature of the larynx. The important thing to know here is which artery does the recurrent laryngeal nerve wrap around. And so the thing you have to remember is that one of them always wraps around the aorta. And as long as you can remember that, you can remember which is which. So the aorta always heads to the patient's left. So that means that the left recurrent laryngeal nerve wraps around the aorta, while the right wraps around the subclavian off of the innominate. So there you go. That was the quick abridged version of thyroidectomy and the anatomy that you need for it. Really appreciate you tuning in. This was Resident ENT with myself, Dr. Joshua Stramiel. Hope you have a good day.